Hello, my name is Pooja Sanghavi, and today we will be talking about demystifying peritoneal dialysis, a blackboard-style video for pediatric residents focusing on peritoneal dialysis. Chronic kidney disease is a state of irreversible kidney damage and/or a reduction in kidney function. We stage chronic kidney disease based off of GFR, or glomerular filtration rate. So there are 5 stages of CKD, and stage 1 we define as normal GFR, which is greater than 90 mLs per minute per 1.73 meters squared. Now stage 2 is GFR of 60 to 90, stage 3 is GFR of 30 to 59, stage 4 is 15 to 29, and stage 5 is GFR less than 15. Now we're going to talk about the symptoms of kidney failure. So most children tend to become symptomatic from CKD at right around stage 3. Some of these symptoms include volume overload, hyperkalemia, metabolic acidosis, anemia, and bone disease. Now, severe symptoms of uremia start to present at around stage 4 or 5 of CKD, and these symptoms include anorexia, nausea and vomiting, growth retardation, which is particularly important for our pediatric patients, neuropathy, CNS disease, and cardiovascular disease. So when is dialysis initiated? Usually discussions about starting dialysis begin around stage 4 CKD, and then the dialysis is actually initiated when GFR reaches approximately 10 to 20. However, sometimes we start dialysis earlier if the patient is having symptoms of failure to thrive, symptoms of uremia, developmental delay, or educational issues. Dialysis in children is almost always a bridge therapy until transplant can occur. Now we're going to talk about peritoneal dialysis versus hemodialysis, and specifically the benefits of PD. First, peritoneal dialysis is a treatment that can be done in the home, while hemodialysis has to be performed in a dialysis center. Home-based treatments are often much more convenient for children and families because they're just less disruptive to their schedules. Second, since children have small vessels, it's sometimes much harder to place large bore HG lines, which is something you don't have to worry about in PD. Lastly, there are smaller fluid shifts, less hemodynamic instability, and more gradual clearance of electrolytes in PD compared to HG. This is because PD usually happens nightly over 8 to 12 hours a night, while HG is approximately a 3-hour process that occurs 3 to 4 times a week. In HD, you have to remove fluid and clear electrolytes in these much shorter, less frequent sessions, versus in PD, where these changes occur slowly over a longer period of time. So in which patients are we unable to perform PD? The first is patients who have a non-functional peritoneal membrane. The peritoneal membrane can be affected by scarring, chronic infections, or adhesions. Since the peritoneal membrane allows for diffusion of electrolytes and osmosis of water, a membrane that is impermeable from the above-mentioned conditions will make PD more difficult. Other contraindications include diaphragmatic hernia or any pleuroperitoneal leak, since we don't want any condition where a PD fluid can enter the thoracic cavity. Gastroschisis is also a contraindication based off of lack of a functional peritoneum. Now, let's talk about the technical appearance of PD. First, a peritoneal catheter is surgically placed into the peritoneum. The first step of PD is the fill phase, where the catheter is used to infuse dialysate into the peritoneal cavity. The second step of PD is the dwell phase. If we were to zoom in into the peritoneal wall, we would see that it is lined with many capillary blood vessels. During the dwell phase, the dialysate sits in the abdomen and water and solutes are exchanged between capillary blood and the intraperitoneal dialysate across the peritoneum. The last phase of PD is the drain phase. During drain, the peritoneal fluid that now contains all the excess solutes and fluid is drained out of the abdomen via the catheter. This creates our basic PD cycle, which is also referred to as an exchange of fill, dwell, and drain. There are 2 main types of PD. The first, which is what we see in 95% of our pediatric patients, is automated peritoneal dialysis. This form of PD uses a machine called a cycler to perform multiple overnight exchanges, and usually leaves a small amount of peritoneal fluid in the abdomen during the day. The cycler has multiple large bags of PD fluid, usually 2 or 3, attached to the machine. The machine has a warmer that warms the fluid prior to it entering the body via the patient's catheter. As fluid enters the patient from the top bag, fluid from the lower bags is pulled upwards. After a set time period of dwell, the fluid is drained out into a drain bag. The second form of PD is continuous ambulatory peritoneal dialysis. In this form of PD, 3 to 4 exchanges are done during the day with 1 overnight dwell. There are 2 main parts of how PD works that we are now going to break down into a more in-depth discussion. The first is ultrafiltration, which is removal of excess fluid. The second is clearance, which is the removal of solutes like urea and electrolytes. Let's talk about ultrafiltration first, which, as we discussed, is the removal of excess fluid. In PD, ultrafiltration is achieved using osmosis, or fluid flowing from areas of high concentration to low concentration. Let's zoom in on our capillary juxtaposed with our peritoneal sac in our abdomen filled with PD fluid. During PD, we use a dialysate that has a high concentration of dextrose, which serves as our osmotic agent. The high concentration of dextrose in the PD fluid will lead to osmosis of fluid out of the peritoneal capillaries, an area of lower concentration, into the abdomen, an area of higher concentration. This fluid will then be removed during the drain phase. PD bags come with specific concentration of dextrose, 1.5, 2.5, or 4.25. A combination of different bags of different concentrations can be used during PD to achieve the desired amount of ultrafiltration. The effectiveness of ultrafiltration is measured by weight. Each child has an estimated dry weight, which is their baseline weight without fluid overload. Pre- and post-dialysate weights are important to help you determine how much fluid was removed during a dialysis session and how close the patient is to their dry weight. So say we have a patient who we think is a little fluid overloaded. How should we get rid of the excess fluid and increase her ultrafiltration? The first thing we could try is to increase the dextrose concentration in our PD fluid. When we increase the concentration of dextrose, we increase our osmotic gradient, which increases our osmosis. The second way we could remove more fluid is to increase the number of cycles or exchanges we do in a night, so that we can continue pulling off fluid with each additional exchange. Now let's talk about the other main concept involved in PD, which is clearance, or the removal of excess solutes. We can break down clearance into two methods, the first of which is diffusion. In diffusion, particles move down their concentration gradient. During PD, urea and other electrolytes will move from areas of high concentration, which is the peritoneal capillaries in this case, into areas of lower concentration, which is the peritoneal dialysate, via diffusion and then be removed from the body. The larger the molecular weight of the solute, the slower it diffuses across the membrane. This explains why urea is cleared much quicker than creatinine. The second method of clearance in dialysis is convection, which we sometimes refer to as solvent drag. The way I like to think of convection is a boulder being dragged in a river. The faster the river is flowing, or the faster your ultrafiltration is, the more particles that are going to be picked up along the way and get cleared out or dialyzed out. Talking about how we measure the effectiveness of our clearance will help us understand how changes in the dialysis prescription affect our ability to clear waste products from the blood. This involves discussing the formula KT/V, an equation that we have heard many nephrologists throw around, probably without truly understanding. So the formula KT/V is used as a marker of adequacy of dialysis via urea clearance. For PD, we aim for a value of at least 1.7. So let's break this formula down into its variables. First, there is K, which stands for clearance. The breakdown of how we calculate K is dialysate urea, which is a measured value, over blood urea, or BUN, times the total volume of drained effluent. For calculation purposes, when we think about the quantity of drained effluent, we can break it down into the total volume of dialysate we are putting in for our exchanges, plus the total amount that we UF, or ultrafiltrate, off. So as an example, say during a night we do 3 exchanges where we fill 100 mLs and then drain it off, and then we do this again for a total of 3 times. The total drained effluent will be this value, 300 mLs in this case, plus the extra amount that we are able to UF off. Usually this total volume of drained effluent is a measured value, but breaking it down in this way will help us understand how changes to the PD prescription change our clearance. Our next variable is T, which stands for time. Usually we use a default of 7 days for this variable. Our last variable is V, which stands for volume of distribution of urea, which is basically what percent of our body weight is water, which is 60%. We calculate V by multiplying our weight times 0.6. So now that we've talked about KT/V, let's talk about how to increase clearance. Let's bring back our formula for K, or clearance. Some of the variables in this formula, like dialysate and blood urea, are measured values, so are unable to be manipulated. What we can modify, though, is the total volume of drained effluent, which, as we discussed earlier, is how much dialysate we are using plus our UF. As we talked about earlier, our total filled dialysate is the number of cycles times our fill volume. Therefore, the first thing we can do to increase clearance is to increase the number of cycles. The second modification we can make is to increase the fill volume. Of course, we can only increase fill volume to a certain point as we are restricted by the patient's abdominal size. The next thing we can do to increase clearance is modify the dwell time. Some patients are able to diffuse their waste products across their peritoneum very quickly, while others need longer. More in-depth discussions about modifying dwell time are a little out of the scope of this lecture. The last thing that we can do to increase our clearance is increase our glucose concentration in the dialysate. To break down this concept, let's go back to the idea of convection or solvent drag. By increasing the dextrose concentration in the dialysate, we are able to ultrafiltrate off more fluid, and with that extra fluid comes a greater concentration of solutes. So now that we understand the basics of how PD works, let's talk about what is the breakdown of the PD prescription. So the things we usually set are the fill volume, the dwell time, the number of cycles we will be doing, and the total treatment volume, which is the fill volume times the number of cycles plus the last fill volume, because we often leave some amount of PD fluid in the abdomen after a night of exchanges. We also always want to be aware of our estimated dry weight to see how much fluid we pulled off. The dialysate fluid has multiple components, starting with dextrose, as we previously talked about, which comes in 3 different concentrations. Another component is calcium, which comes in 2.5 to 3.5 milliequivalents per liter, although the standard is 3.5. Hyperphosphatemia is a problem in patients with CKD, which can lead to low calcium levels. Calcium is added into the dialysate to ensure that the body's needed calcium is not dialyzed off. Other additives include sodium, potassium, which is not usually used but can be added for patients with hypokalemia, magnesium, and lactate. Heparin can be added into the dialysate to decrease the activation of fibrin and avoid clotting. Interestingly, the heparin stays localized and does not have systemic effects, so it can even be used in patients at risk for systemic bleeding. Heparin is often added in during episodes of peritonitis, where there can be an increase in fibrin development. Lastly, antibiotics can also be added directly into the PD fluid to treat peritonitis. Now let's talk about some of the complications associated with PD. The first complication we're going to talk about is exit site infections. Catheters can frequently become colonized with bacteria, which leads to biofilm formation. Infections may involve the exit site alone or involve the tunneled portion of the catheter. These infections will present as increased crusting or erythema surrounding the site with possible serous or purulent discharge. If the tunnel is involved, the patient may have erythema, edema, or induration around the pathway. These infections are diagnosed with gram stain and culture of the effusion. The treatment is based on the microbiology. The most common cause of these infections is gram-positive organisms from the skin, like Staph aureus. We treat these infections with cephalexin. Gram-negative pathogens like E. coli and Pseudomonas are treated with ciprofloxacin or intraperitoneal ceftazidime. If the gram stain is unavailable, we treat for both. The duration of treatment is a minimum of 2 to 3 weeks or until the infection is completely resolved. Complications of these infections include abscess formation or peritonitis. Catheters only need to be removed if there is progression of the infection to peritonitis during treatment, an infection resistant to antibiotics, or an infection caused by a fungus. Most children on PD use a daily topical antibiotic to prevent infections. The second complication we are going to talk about is peritonitis. Signs of peritonitis include cloudy effluent, abdominal pain, and fever. Peritonitis usually occurs due to contamination of fluid during hookup or draining. If peritonitis is suspected, effluent fluid should be sent for a cell count and culture. Peritonitis is diagnosed if the effluent leukocyte count is greater than 100 or has greater than 50% neutrophils. Peritonitis is most often treated with antibiotics added directly into the PD fluid. The initial treatment is usually empiric with vancomycin and cefepime. Culture results allow the antibiotic regimen to be refined. The last complication that we are going to talk about is hypotension or dehydration. Monitoring blood pressures is critical in dialysis, as aggressive reduction in blood volume can occur from overfiltration. Some common symptoms in this situation might be lightheadedness, weakness or fatigue, irritability, tachycardia, nausea, or muscle cramps. If you are posed with a patient who is persistently hypotensive during their nightly PD session, things to think about include: is the dextrose concentration too high? Is our dry weight estimate off and we are dialyzing to too low of a weight? Or is the patient on any antihypertensive medications that are worsening his or her hypotension? And that covers our basic review of peritoneal dialysis. Thank you so much.